We are live now. Welcome, Sujaya.
Hi, ma'am.
It's 5 o'clock now and we are live. So, Sujaya, would you like to start?
A very good evening to everyone. So welcome to today's session, Searchlight 27, which is on fibroid mapping. This program is in association with Khora, Makanpur, Palanpur, Perinthalmanna, Porbandar, Pune, Ranchi, Rewari, Rohtak, and Amravati societies, in association with Cancer Initiative. So firstly, yeah, that is myself. So we will skip this slide.
So I will introduce you. So I would like to introduce the convener for this program, Dr. Sujayasri Sangita. She is an MS Gynae. She is
Hi, Asha.
Namaste, Didi.
Hi, ma'am.
What a pleasure. Karo discussion. I'm enjoying.
She is a consultant
Good evening, ma'am.
in lab surgery at Seshadri Hospital, Palakol and Malkapuram. Founder Secretary of Bhimavaram Society. She has Shane Ratnam Young Gynecologist Award, Foxy Dhira Award. Her areas of interest are laparoscopy and infertility. So welcome, Sujaya.
Yeah, thank you for that kind introduction, ma'am. So now it gives me great privilege to be introducing the program director, who actually needs no introduction, Dr. Asha Jain, ma'am. She's currently the director of SMSA Hospital Raipur. She is the medical director of CPRS. She has been the elected member of CG Medical Council, and she has been the zonal chair, Foxy Food Drug and Medico-Surgical Equipment Committee, West Zone. Past offices, President Raipur OP-GYN Society, Vice President of IMA Chhattisgarh, and President of Rotary Club of Raipur North. So currently, ma'am is standing as a chairperson of Committee of Food, Drug and Medico-Surgical Committee. So kindly support ma'am. And I request ma'am to please take over.
Thank you, Sujaya. So I would share the screen and welcome all the respected faculty to this webinar. And as usual, we would first take the blessings of the divine and then proceed with the program. So I wish everybody joins hands for blessings from the divine. So I welcome everyone to this webinar, Searchlight 27, on updates on fibroid uterus. Dr. Alka Kriplani ma'am has kindly consented to be our chief guest, and Dr. Sushila Pinnamaneni from Vizag has consented to be our guest of honor. We have two fabulous speakers. Dr. Ashok Khurana sir will be speaking on ultrasound mapping of fibroids, and Dr. Mala Raj from Chennai will be speaking on surgical treatment. we will have a panel on medical management of fibroids after that. So I would like to introduce Alka ma'am. Welcome all dignitaries. Welcome all delegates to this 27th Searchlight. It's a very, very, very great honor to introduce Dr. Alka Kriplani ma'am, who's an ex-professor and head Department of Gynae, AIMS, Delhi, and Chairperson, Department of Gynae, Obstetrics and ART at Paras Hospitals, Gurugram. She has been President Foxy, President JC, President DGS, President AOGD, editor of the Asian Journal of Obstetrics and Gynec Practice 1919 to 2017. And she is on an editorial board of 9 journals. She has 47 awards, the biggest being the Padma Shri, which was awarded in 2015 for distinguished service by the President of India. She also has the BC Roy National Award for Eminent Medical Teacher in 2007, Honorary FRCOG, Medical Teachers Award, IMA Med Achievers Award, Vidya Bhushan. So welcome, Alka Didi. We would really love to have your blessings, and on some future date, we would really like to hear you in a lecture as well.
Thank you so much for your kind words, Asha. It's an absolute pleasure and privilege to be with you people today. And I know you are so active academically, socially, and I have a very, very special affinity because I'm also from Raipur. And all my schooling and medical training is from Raipur only. So we are from the same village. Now it is big city. It's a honor to be with you all. And myoma, it's such a common problem. 20 to 30% of patients have it. And really you have to have individualized approach for management. So the diagnosis is very important, and I shall be failing in my duty if I don't appreciate Dr. Ashok Khurana, who is an excellent teacher. And for years, he is teaching so well. You see his sessions, how the people sit and take notes. On the top of it, he is sacrificing. He has dedicated time for teaching. In the extended weekends, he is doing teaching for years. So this thing is really needs to be appreciated, especially when one has such heavy practice and dedicating time for teaching. So it's a day for teachers. If I can, I will also sit through his lecture because they are very updated and very nice. And then coming the now emerging role of medical treatment in management of myoma. Dear friend Mala Raj, who is doing such good work in endoscopy, she is going to show you, I'm sure, her wonderful videos and work on laparoscopic and hysteroscopic management of myomas. And then very pertinent topic, because many situations you just want to pass off time and not every fibroid needs to be treated. So medical treatment of myoma. So program is wonderful. It will update everybody. And Asha, I really appreciate your energy and your dedication and your perseverance. So wish you all the best and happy learning.
Thank you, ma'am. Thank you so much. Thank you. So now I would take the program forward and share the CV of our guest of honor, Dr. Sushila Pinnamaneni, past president of Vijayawada Obstetric Gynec Society. Welcome, ma'am. Ma'am is the consultant obstetrician and gynecologist at Lata Super Speciality Hospital, Vijayawada. She has been the president of Vijayawada Society 22-23. Before that, the secretary, organizing secretary of first APCOG 2015, delivered prestigious Foxy ICOG Dr. C.L. Zaveri Symposium at AICOG Calcutta 2023, IMA AP State Dr. Guru Murthy Memorial Oration in 2023. She has the Foxy Achievers Award in the year 2023. She has authored various books, and she has kindly consented to be here with us today. Welcome, ma'am. Welcome to this forum. And we are waiting to hear some words of blessings from you.
Thank you, Dr. Asha, for the kind introduction. I've been listening to you, madam, since the last year when you have started the Searchlight program. They're so very important webinars on important topics. And you have been so active and passionate in sharing knowledge, which is very important for the students and also the young colleagues, and also updating the knowledge for everybody. And today's topic is, as Dr. Alka Kriplani said, it is a very pertinent topic, and we need to update regarding the day-to-day practice also. And you have really good speakers, Dr. Mala Raj and Dr. Khurana sir, are going to enlighten. And I think by the end of this session, everybody will be like full of knowledge. So without any this thing late in the program, I wish you very best for your endeavor as the chairperson, and all the best to you, madam. Thank you.
Thank you so much, ma'am. Thank you so much for those kind words. And with this, we are at the end of our inaugural session, and we start the academic session. Requesting Dr. Sujayasri to please introduce our chairpersons.
Thank you, beta. कहीं तो जाना नहीं है.
You are muted. Sujay, you are muted.
Sir से
Yeah.
पूछिए.
Moving on to the first
मुझे नहीं
session on
लगता है.
fibroid mapping. Firstly, I would like to introduce the chairpersons of this session. We have Dr. Somna Goyal Mittal ma'am with us, who has more than 28 years of clinical experience in the field of OB-GYN. She's a senior consultant at Yashoda, Kaushambi and Max Vaishali in Ghaziabad. She is the president of KMOGS, and her areas of interest are high-risk obstetrics and infertility care. Welcome to today's session, ma'am. Next, we have with us Dr. Kochu S. Mani, ma'am. She has started her career as a consultant in 1991. She is currently the HOD in the Department of OB-GYN in EMS Memorial Co-op Hospital. She's also visiting consultant at Maulana Hospital and also a superintendent at EMS Hospital. So she has been the vice chairman of Pain and Palliative Committee. She has trained in laparoscopic surgeries. So it's an honor to have you with us, ma'am. Welcome to today's session. And I request Dr. Somna Goyal, ma'am, to please introduce the speaker, Professor Ashok Khurana, sir.
Thank you. At the outset, I would thank Dr. Asha Jain, ma'am, and the organizers and the Searchlight team for inviting Khora Makanpur Society. And some few words about the fibroid. We know daily in practice we are facing many patients. Almost 20 to 30%. It is the commonest benign gynecological tumor, and many of them are asymptomatic, but they symptoms of severe amenorrhagia, abnormal uterine bleeding, dysmenorrhea, pelvic pain, anemia, and infertility is also associated with these fibroids. If in good hands, like the modalities, diagnostic modalities, they can do location of the fibroid precisely and help in guiding the future treatments also. So from this, I invite Sir Professor Ashok Khurana, sir. We all know he doesn't need any introduction. We always look to him for guidance and the best diagnosis whenever we are in a mess. Sir is MBBS from the All India Institute of Medical Sciences, New Delhi. Is MD in radio diagnosis from AIIMS, New Delhi, and trained at the Herlev Hospital in Denmark in ultrasound. Sir is a consultant and chairman in reproductive ultrasound lab, New Delhi, practicing ultrasound since 1980. He is Professor, School of Health Sciences, Croatia, Professor, Indian Medical Association, 2017 to 2020, and past president of Society of Fetal Medicine. Former ISU International Sonography of Obs and Gynae ambassador in India. Former Dean, Indian College of Medical Ultrasound, and mentor emeritus, Society of Fetal Medicine, and he's editor-in-chief, Journal of Fetal Medicine. Sir has many accolades to him, awards to him, and with this I welcome Sir for Ashok Khurana sir for this talk on fibroid mapping.
Welcome, sir. It's such a great honor to have you with us and see you ever smiling. In spite of all the work you do, you're always smiling. So welcome, sir.
Thank you. Thank you very much. It is indeed an honor to be here. And I was so pleased when you invited me for this. And I said, wow, this is an opportunity. I'm going to start sharing my screen so that we get going with this. My thanks to everyone for those very, very kind introductions. And I am looking forward to sharing some of the new things with you and sharing some of the older things as well. And I will take you through mapping of fibroids, how and why. And I'd like to take this opportunity also to very much thank Dr. Alka Kriplani, my favorite surgeon in the whole of the NCR, from whom I've learned a lot because of the wonderful feedback she's been giving me over the years for what things look like at surgery. And I'm so glad she's here as part of the team today to listen to this. So plunging straight into fibroid mapping, as you see on this introductory slide, we do realize that there is this absolutely fantastic change in the way we now look at fibroids on an ultrasound scan. And we have routine transvaginal scans. We have the ability to slice through just like we do for CT and MRI, and we can study vascularity. And these are the things that have changed our complete approach, because after all, fibroids are something that we cannot handle on a casual basis, as you learned already. What we have understood is that they may be asymptomatic, and as Dr. Kriplani highlighted, they could also present with a variety of symptoms, including heavy and abnormal uterine bleeding, pain, pressure effects, infertility, and recurrent pregnancy loss. They vary in number, size, location, and echogenicity, and describing and displacing this number, size, location, and character is what we call fibroid mapping, because it's very, very useful. It not only guides patient options, but also patient counseling. It's also very important because we must know that it is very useful to assess that fibroids are the cause of symptoms. I mean, that's what the patient has come to you with, and that's what we need to give a relief for. And if we're going to say have a surgical approach, then we jolly well be responsible for saying that, look, you're likely to benefit from this particular treatment. Also, as you will understand in my next slide, we have a plethora of gynecological management options, which are going to be discussed today in detail. And fibroid mapping is central to offering these treatment modalities to the patient, whether we choose a surgical option, a medical option, or a masterly inactivity type of expectant option. Also, mapping guides intrasurgical management, and that becomes very important. And when non-surgical options are chosen, mapping is useful to assess therapeutic response. And so it becomes necessary. And as these images show us, so far we've been using different methods of highlighting fibroids. And most of these are images on which someone has done photoshopping. But really, we must understand how these are located and what is new about this. And that is what I'll take you through.
Anupa?
Because when we look at surgical care for fibroids, we understand that there's a whole new perspective. You see, there is also what has been introduced already is non-surgical versus expectant versus operative management. And this is what we're going to discuss today. And central to that is what type of surgery, because we have had the emergence of minimal access surgery. We've had the research of vaginal surgery. Then we have a lot of patient expectations and counseling, and this forms a very important part of the doctor-patient relationship today. Then from an administrative point of view, you have to have some rough idea of the duration of surgery, the type of anesthesia, OT scheduling, which is very important in multi-specialty hospitals. And then, of course, this great question for the surgeon of operative access and whether we can get down there, or is everything in the pelvis just plastered together. And when I was doing a vaginal scan, did everything move or did it not move? And so on. And that then also will decide what is going to be the duration of surgery, the possible complications, and the outcome of surgery. Also, there's a huge thing now about the choice and availability of instruments. And we do understand that this is very, very important, that not every OT will have all the instruments all the time. And some of us might actually rent them out. Some of them might want the best. And there might not be every OT that we go to that has the same instruments. And we have to make sure that, okay, I'm going to have to use this, and is it available there? Then, of course, there's budgetary considerations and the fact that you want your surgery to be as complete and successful as you had originally planned. You don't want to, for instance, a colleague to discover shortly after surgery that you didn't do a full job. And therefore, it becomes very important. And then, of course, the final thing, that this budgetary constraint thing is important. And we must understand that, yes, we are giving medical recipes, but in today's world, we need to also discuss with the patient what are the costs of technology, etc. And therefore, it became necessary for all of us to understand the why fibroid mapping, which we will discuss a little further, but equally important, how. So I will discuss the modalities we use for the imaging of fibroids and therefore the fibroid mapping, the words we use in our description, some of the classification systems so that the person who's doing the imaging and the person who's doing the surgery are on the same page, or even for a general practitioner who's giving the patient the options, we should know this. And we'll also introduce you to the new software that is available on the basis of now artificial intelligence. So as I've shown here on this title slide, you do find the fact that artificial intelligence on ultrasound can give you an outline of the whole uterus. It can give you an outline of the actual cavity. It can give you the axis, the long axis of the cavity. And on this, the artificial intelligence can actually superimpose. So the map is something that you don't need to have a deep knowledge of ultrasound. It's something that you and me are seeing on a usual basis. And I will show you how we are now currently using that a lot. For the sake of postgraduates and the academics, and because I don't like to repeat the references again and again, those of you who are interested can take a list of these references. You have an excellent article from 2016 on uterine fibroid mapping from Nusser, and the MUSA statement from the MUSA group, the FIGO-PAMCO classification from 2011, the American Association of Gynecological Laparoscopists practice report from 2012, and the Canadian Clinical Practice Guidelines from 2003. More recently, there's a very nice input on Human Reproduction Update 2016 on fibroid management from the present to the future. But really what you and me are going to set out to do is to see what does a fibroid look like, what does a uterus look like, how much of it is in the cavity, how much of it is not, put it into the perspective of the FIGO classification, study it with color so we know whether it's very vascular or not, or is there a bizarre pattern that I might need to be careful of a sarcoma in the first place. And then typically today, I make a map that correlates with what we imagine from a textbook image to be. So here is the outline of the uterus on 3D, and this is the cavity here. And we have a fibroid polyp lying, a large fibroid polyp lying completely inside the cavity. Some of us with experience will be able to tell all of this from a 2D image like the one here. But most of us will see a little more from something like this. And now we move towards an AI type of mapping, which I will discuss with you. Now, we will spend the rest of the day discussing, the rest of the evening discussing the surgical options, the non-surgical alternatives, and the medical therapy. So I won't delve into that. I will move on straight to talking about the imaging modalities. And we do understand that we have conventional equipment, such as the transabdominal transducers in 2D, 3D, and power Doppler. But really what we end up using is a transvaginal transducer, because we place this right next to the uterus transvaginally, and you get a much higher resolution of the image, and you can also get much better measurements and much better delineation of the smaller lesions. Also, the resolution of a transvaginal ultrasound is better, and therefore you can map these much better. You can then go on to combine that with 3D and 4D, which gives a more understandable picture. Make sure that you're not missing anything from left to right, top to bottom, and front to back. and then combine it with the simple AI that has now been incorporated in many machines that have been available since the last year or so. There is also MRI, which we will discuss briefly, but typically speaking, because of the accessibility and relatively low cost of ultrasound, it's available everywhere. It is really the primary modality, but we always keep in mind the fact that it has significant operator dependence, which means that the reproducibility from someone who's more experienced or someone who is using a high-end machine is always a little more reliable than someone who is not. Also, what happens with MR is that it's technician-based, so it may not always be the best. So sometimes it's a ping pong between the fact that is 3D ultrasound better or is MR better. In general, MR is more expensive. Therefore, mostly ultrasound remains the modality for choice of imaging and mapping fibroids, and we will discuss the special situations in which MR is to be used. For actually mapping these fibroids, you can either do a transabdominal survey from above, especially in patients who have never been active, although what I prefer to do most of the time is actually do a transrectal scan if that's acceptable to the patient. And if that gives us information that is good in the patient who's not been sexually active, most of the time we do it like I showed you, where we map the fibroid with a transvaginal scan. We can also use 3D to demonstrate these, and you can use it either with automation or without. And this automation is now inexpensively available on everything. And then, of course, like I said, you can map them with MRI. Now, in mapping, it is important that we go from one end of the uterus, which is the left or the right side, to the opposite end, look at the endometrium and the myometrium, spot the fibroids as we go across to the end, and then try and identify. So here is a fibroid sitting with indenting the cavity, and I need to mention where it is. And there's another teeny weeny one, which is going to be coming up soon in the anterior portion of the myometrium here, which obviously we're not going to do very much about. And therefore, we need to mention this to the patient that you have a second one. It may come up in the future. If this is a young person, we might opt for different options. And if this is a person who's fed up over periods of the last 10 years and is having perimenopausal difficulty, we might offer her a hysterectomy as an option. So this is how these maps actually help us. But the map has to be complete by making sure that the transducers move from left to right, front to back, and side to side. Just fiddling around in one area where you see most of the lesion is not enough and can never be complete. So the sweep of the ultrasound for mapping should never be inadequate. Now, we must also understand that sometimes you don't need advanced technology. So if you have like 1 or 2 fibroids and you see the endometrium separately, you're comfortable. Or otherwise, you definitely need it. For instance, if you look at these cases, these are 3 separate cases. And you can see that there's broad fundus, for which actually we would expect adenomyosis on a laparoscopy. But if you mapped this uterus earlier, you would understand that this broad fundus is because of 2 fibroids extending, one nearer to the cavity to the mid fundus and one extending from an intramural location to the fundus. And of course, distorting the cavity considerably. This one is a hemiuterus on the left side and a rudimentary horn showing a fibroid growing there and therefore resulting in a broad fundus and not the small uterus you would expect with a hemiuterus. Here again, a wide uterus. Here you have a large fibroid which is displacing the cavity but not actually distorting it, and the fibroid extends all the way from the surface to the inside of the cavity like you see here, and therefore we describe it accordingly. If you have multiple fibroids, then of course each one needs to be described separately, and you realize that the coronal format that we use in 3D, A, gives you a much better view, a much better understanding, but also gives you greater contrastiness, and that becomes very, very useful. Color is now routine to be used and is available on virtually every machine. And it's very important because you want to assess the potential for blood loss as well as to make sure what kind of a lesion you're looking at. Also, 3D is not just simple surface rendering, as I've shown you here, but advanced engines which can show you not only cavity, but fibroids and all the little teeny weeny fibroids highlighted, because we make lines instead of texture, and that can really give you a much better map. So it's basic 3D and advanced 3D. There's routine color Doppler, and of course, 3D is now emerging as something we use routinely. Also, 3D might give you an idea of etiology in terms of pathology of the lesion. These three are three different uteruses. Hypoechoic lesion in the posterior wall, poorly defined posterior wall of the lesion. Here again, cavity component, posterior wall extension, and cavity component, posterior wall extension. Technically, these are all slightly heteroechoic lesions, but look what happens when you add color. This one shows peripheral flow, so you know that this is a fibroid. This one shows a sunburst flow in the middle, so you know that this is an adenomyomatous lesion.
Excuse me, sir.
Yes.
So it's not coming. It's not coming. The Doppler view is not coming.
Ah, the Doppler view is not coming. I will try and see if that.
Yeah. It came.
It came, huh? How about now?
Yeah, it's moving.
Yes. So this one at the bottom right is the one that is peripheral flow, and therefore this is a fibroid. Sunburst flow in the center, and therefore this is an adenomyomatous lesion. And then you say, okay, this one is a pool of blood, and this one therefore is an arteriovenous malformation, or what we call enhanced myometrial vascularity, and therefore is not something you would ever handle lightly. On the other hand, you know that if this is causing pain or infertility, you'd rather remove it sooner than not, and the prognosis would be different. And a fibroid, you could give them options and say, okay, this can happen. That's what, of course, we're going to discuss the rest of the evening today. Now let's take a look at this uterus here. And you see, all right, there is endometrium, there is a fibroid here, and there's a general inhomogeneity. And then you see, okay, so this must be adenomyosis plus the fibroids. You don't want to miss anything. The first thing you do is to switch on color, and you realize immediately that in that color, you are able to pick up this peripheral flow and not central flow. And you know that, yes, this is therefore a fibroid within an adenomyosis, and that is what we're looking at. This is what I was referring to otherwise, to try and see what lesions are all about. Longitudinal section, slightly pushed cavity on one side, but we're not sure whether it's truly pushed or not. And there is this lesion extending beyond onto the serous surface from inside, and you want to figure out what it is. And of course, another teeny weeny lesion next to it. Now, the moment you put that artificial intelligence on, it's a single button, fibroid mapping. It identifies the outline of the uterus, identifies the cavity, measures and maps these fibroids, and then you can rotate it around to understand whether this lesion at all touches the cavity, and it's obviously that it doesn't, and that this other lesion also does not touch the cavity in any way. So both this lesion and the one next to it are not submucous lesions, and therefore have to be approached differently in terms of surgical options. Sometimes it's not possible for the machine because these fibroids are all isoechoic, which means the same echogenicity as the myometrium. Then you can do the same exercise manually, but the AI function still works. And we will show you some cases as we go along. The other way to map fibroids is MRI. It's the second most commonly used modality. Very useful for very large lesions because that's the best way to deal with large lesions, which means typically uteruses that are more than 16 weeks to 20 weeks in size. Also, that if you're considering the option of an MR-guided focused ultrasound, if a fibroid is bright on T2 images, then you will not attempt MR-guided focused ultrasound. It doesn't work. Given the constraints of cost, time, and expertise, MRI is best suited for selection of women who are either undergoing umbilical uterine artery embolization, MR-guided focused ultrasound, or where your primary ultrasound is not able to give you the kind of information that you're looking for. And when someone works hard on these, that means the technician and the radiologist, then you can see a good longitudinal section. You can see the degree of distortion of the endometrium, and you can also see the extent of the fibroid from its submucosal extent, from it up entering into the cavity a wee bit, but not extending to the serous surface. So this is how you will get that information. Or if they're multiple, then again, this little fibroid here, which is far away from the cavity, this one, which is cavity plus serous, so Figo 2-9, and this one, which is indenting the fundus as well as coming to the cavity, and therefore has to be handled very differently. Then there is this one here, where the bulk of the lesion that we see here is still within the wall. And then, of course, you also see a few type 5 myomas, or this one here, where everything is right inside the cavity. So there is no doubt that the degree of contrast and spatial resolution on good MRIs is better, but also on high-end 3D, the resolution is pretty good, but it takes a lot more expertise. But then let's face it, even MRI today takes a lot of expertise, so there's no shortcut, and we should go step by step. With ultrasound is the first step, 3D ultrasound is part of ultrasound, and of course, MRI as a problem-solving modality. We like to use standard words, which we like to use between all teams handling the patient, which means A, when we measure the uterus, we will include a longitudinal from the fundus all the way to the internal os along a curve. We will include the widest anterior-posterior diameter, and we will include a transverse diameter. Then the next thing that we have to do is to mention whether the outline is lobulated or not lobulated, and then go on to describe each one of these fibroids. If they're globular, 1 diameter is enough. If they are not, then we'd rather mention 3 rather than 2 diameters, and that is how it works. It is also important to define on every single lesion on how far the cavity aspect is far away from the true cavity. So this green dotted line here. Also, how far is the serosal aspect of this lesion away from the true serous surface, this yellow dotted line over here. So the actual measurements here must be mentioned in a report, irrespective of who's doing the ultrasound. We also like to make sure that we figure out which one is anterior wall, posterior wall, which ones are fundal, go on also to describe right and left. And then if it's in the corpus, we like to differentiate between an upper corpus, a mid corpus, and a lower corpus. And of course, they could be overlapping. That means lower and mid, or upper and mid, or all the way from lower to upper corpus. The more descriptors we use, the lesser the communication gap and the better the patient outcome. We, of course, tend to use more and more the Figo classification, where we automatically label all the pedunculated intracavity as 0, Figo 0. And then Figo 1 are the ones that have less than 50% in the wall, as you see here in the yellow one. Then you have this blue one, which is labeled 2, where more than 50% is in the wall. You have a fibroid, which is Figo 3, which is actually all of it intramural, but it does have endometrial contact. If the whole thing is intramural and has no contact with the cavity or no contact with the serous surface, that becomes a Figo 4. If most of it is in the wall, but it does have a subserous aspect, that becomes a Figo 5. And if the bulk of the lesion is outside the serosal surface, that becomes a Figo 6. You could also have, of course, pedunculated going beyond the serous surface, and that's a 7. And then you can have fibroids that are all the way from a cavity component to a subserous component or a serous component, and that becomes a 2-5 or a 2-4 or a 3-6, depending on what numbers you choose. Remember also that sometimes you could have fibroid that are wandering all over the place, or a broad ligament fibroid, for instance, which then has to be described separately. But a lot of fibroids are hybrid leiomyomas, and we should not hesitate to give them more than one number so that there is no communication gap. Remember that fibroids may also be in the cervix, and then they become type 8, and they could be parasitic, where they travel way beyond the uterus, and that is also type 8. The other thing to realize is that sometimes a 2D may not give you good orientation. So you do see the cavity, but you also see fibroid. And then it's only 3D that will show you that, look, the bulk of this uterus is fibroid. The whole cavity is not distorted, but displaced lower down. So this portion is normal. The rest of this fibroid is extending way beyond the serous surface. That is true fibroid mapping. We must also realize that on ultrasound, we often see these as echogenic lesions if they're polyps, but most fibroids will appear hypoechoic. But not all hypoechoic lesions are fibroids, and that differential diagnosis must be maintained. They could be, of course, fibroid polyps. They could be adenomyomatous lesions, or adenomyotic lesions, I should say, or they could very well be very, very thick synecdoche. So shadows will not necessarily tell you about the pathology. Of course, we always switch on color to differentiate between a fibroid and an adenomyoma. And then, like I said, it's nice to be able to slice like an MRI and CT and go from side to side. So we have a uterus here with a thickened posterior wall, adenomyosis in this part of the wall. And then you see, is it adenomyosis or is it a fibroid? I will have to confirm that with color. This one looks more like a fibroid. And then we slice it and you see, okay, there's a bit of menstrual fluid inside the cavity, but you could also instill fluid like we do in sonohysterography, sometimes required. Most 3D tells us these days that you don't require it. And then you see, okay, the 3D shows me this kind of a pattern, which is characteristic of a fibroid. So this is also a fibroid. This is also a fibroid. This is a 2-5 fibroid. And this one is also 2-5 fibroid because my cavity should have been like this. And therefore, my surgical approach to this would be different. Or the fact, if the patient is asymptomatic, I could very well leave this alone and say, come back, blah, 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 blah. Now, look at this lesion. I see a very good looking cavity in a midsection. When I do a transverse section, I see most of the cavity. I see a bit of shadowing from a fibroid, which is very common. And I'm not sure whether this truly touches the cavity or not. I do a 3D reconstruction with the newer rendering engine, and I find that there is a pretty decent line outlining my cavity and not the fibroid going into the cavity. And I want to be absolutely sure, because if I'm going to be touching this, am I going to open the cavity or not? What's going to be the prognosis? Does this patient have the option of getting pregnant as soon as possible or not? All these are things, of course, that you will hear in the rest of the evening. But from my side, from a fibroid mapping point of view, I'm able to rotate that AI image and prove that, yes, there is a very clean plane between the cavity and this lesion. And therefore, if I were to use an outer approach, laparoscopic approach, there's a good chance, if I find the right cleavage, I'm not going to be able to enter the cavity. I'm not going to enter the cavity, and that's really nice. I don't wish to enter the cavity in this particular situation, so that you can try and conceive a little sooner. Then, of course, there are some which are very simple. You don't need any of this mapping. It's a nice, clean uterus, a few intraepithelial polyps, but otherwise, just one odd, small upper corpus, teeny-weeny subserous fibroid, the bulk of which is outside. So this is a type 6, and that's what the AI confirms for you. On the other hand, look at this lesion. And I've shown part of this to you before, where I showed you this one where I wasn't sure whether it was adenomyoma or not. But now I start mapping this. I press one button. My transducer sweeps through. I don't have to make any effort. All I have to do is to outline the cavity, which I will make a line like this on the honest cavity. And then when I look at it, I have these two fibroids. And you can see there is this one, which definitely indents the cavity, and this one that just about misses the cavity. And then I rotate and I say, aha, this is what sometimes fools the eye in 2D. This one definitely cavity component. This one, not really. All that distortion was because of the distortion by this, because I have an outline of the cavity here, which guides me that I am on the right lines. Moving on, let me see some more fibroids. And we have here this one, where I see two lesions, a cavity here, a heterogeneous lesion here, another one here, both about 1.5 centimeters. I press my button. It gives me an outline of the uterus, obviously a globular uterus, and I can see the adenomyosis, a cavity that is here, and then the fibroids are outlined 1, 2, and 3. And then I rotate by pressing my rotation button, and I say, wow, truly speaking, I have here none of them actually distorting the cavity beyond a point. And then when I rotate, I realize that yes, the cavity is here, it's a baggy cavity, but none of these fibroids has an inside the cavity component. Yes, it's a lobulated uterus, it's an adenomyosis plus fibroids, and we have all the other things to consider, but none of these is in the cavity, and that's how simple this technique becomes. If sometimes the fibroid doesn't show up with this circle, all I do is put one dash here, one dash here, one caliper, and the machine does the rest without being prompted to do so. And another simple example here, there is this fibroid here, far away from the cavity, confirmed, and I feel very comfortable with this kind of a fibroid map. What about here? Two fibroids, this one and this one. I'm not absolutely sure how much is, which one is cavity, which one is not. I put my AI function and I get the cavity. I get one, which is a lot inside the cavity. And then this one, the two, which I rotate, and I realize when I rotate in different directions, in my X and in the Y direction, 2 is actually a type 4 and not a type 2 kind of lesion. 1 is a Figo 2, but fibroid number 2 is a Figo 4. So this is the advantage of using this. A few more examples that when there are lots of fibroids and you want to be absolutely sure, again, this AI function can truly help me to decide. And in fibroids, say perimenopause, bleeding heavily, I spot this lesion here in the cavity. I'm reasonably sure that this is the cause of my bleeding, but I want to be sure how much of the other fibroids, and the uterus is full of them, are responsible, and what is the status of this one here. I switch on my button, I outline the cavity, and it shows up here. And the moment I see that, I realize, aha, there is this number 1 and 2, which have cavity components. My 1 is a fibroid, which has a major cavity component. My 2 is bulging a bit. The rest of them are on the outside. I then start discussing her symptoms with her. And she says, look, I cannot afford to get my uterus removed. I have my exam, this, that, and the other. I said, yes, but your hemoglobin is so low, you're bleeding so heavily. Okay, as a stopgap, I might consider removing the polyp first, but no promises. And you'll have to come back and meanwhile make up your mind what you want to do. You're 50, but that does not mean that you will menopause tonight. So do think of all of this and we'll discuss it again. So really step-by-step decision-making in fibroids. In the good old hysteroscopic approach, we often use the Wamstecker classification of 0 totally in the cavity, 1 more than 50% and 2 less than 50. But we also added a new component, which is part of the LASMA classification, where we added on the penetration of the fibroid into the myometrium, the largest myoma diameter, the degree of extension of the fibroid to the endometrial cavity surface, the location on the uterine wall, whether upper, middle, or lower, and whether it was lateral wall or not. And to each of these, we then give a score of 0, 1, and 2, depending. So for instance, for penetration, if there's no penetration, it's 0. If it's less than 50% in the wall, then that becomes a score of 1. And more than 50% in the wall, that becomes a score of 2. Of course, the rest of the FIGO stuff of 0, 1, and 2 remains the same as in the FIGO classification. Now, if the score is between 0 to 4, there's a rough guide here of a low complexity hysteroscopic myomectomy. If the score is between 5 and 6, complex process, and you might, in case you're one of those who is a proponent of GnRH, decide either that or a 2-stage surgery. And if it's 7 to 9, it's better then not to consider a hysteroscopic approach, but to consider a non-hysteroscopic technique. So that's how even simple mapping with simple LASMA score can help you for everyday decision making. And for this, you don't need any artificial intelligence. Reports, of course, should be as descriptive as possible. But to summarize, it is now obvious that ultrasound is actually, and this is from the Canadian guidelines, that ultrasound is a recommended initial imaging modality. And of course, you will then be able to tailor the treatment depending on the size and location of fibroids, but also what we're going to learn later today, the patient's age, symptoms, the desire to preserve fertility, the access to therapy, and so on, and of course, the physician's experience. The expected management is appropriate for women with asymptomatic fibroids. This is also part of the recommendations from Canada, and I like to use these. And of course, in women undergoing hysterectomy for treatment of fibroids, the least invasive approach should be chosen, and fibroid mapping seems to fulfill that. And then, of course, MRI for problem solving. And with that, I come to the end of my presentation, and thank you so much for your attention. There we are. I realize that a lot of my friends from around Delhi have also joined here. It's so wonderful to see everyone here.
Sorry, sir. I just received a call from Ambuja, ma'am. She was listening and complimenting on the phone. So,
oh, thank you. Thank you.
So that is why I didn't speak up. Dr. Kochu Mani, are you there? Requesting you to say a few words, ma'am. Ma'am, you need to unmute yourself.
Yes, ma'am. Yes, ma'am. I'm here. It was really an excellent talk, ma'am. So we could, he taught us so many things, but we have to see when we are planning for the surgery or whatever may be the management, and how to, this one, that mapping is very to know the size, location, and the number and the invasion of the uterus or not, everything. Really an excellent talk. I have no words, ma'am. Thank you, sir. Thank you very much.
Thank you indeed.
Thank you, sir. And anyone else wants to say something? Dr. Aarti? Ma'am, you're muted.
Yeah, yes, ma'am. I want to ask the sir, the vascularity of the fibroid indicates the growth of the size of the fibroid anyway?
Yes. You see, rapid growth of a fibroid does not make us very nervous. We see that happening in a single cycle. We see that happening in any sort of estrogen surge. We don't get worried. In the mapping, we look at the type of vessel. Typically, vessels in a fibroid would be on the periphery. And they give off one side vessel at a time. Then the vessel becomes narrow and keeps giving off one side vessel. If any vessel going into a fibroid becomes double, then I start suspecting sarcomatous change. Dichotomous branching is a sign of a sarcomatous change. Or in case the parent vessel is narrower than the daughter vessel. Larger daughter vessels are again an indication of a possible sarcomatous lesion rather than that. Of course, a lot of us believe that sarcomatous lesions will always be sarcomatous and that benigns don't turn that, but that is theory. What I need to assess from my patient's point of view is what is the trouble that I see here, especially because there's been so much noise about spilling into the peritoneum when we use minimally invasive techniques. So vascularity is an integral component of assessing fibroids.
Okay, sir. Thank you. Thank you very much.
Thank you, sir. Very, very, very honored to have you with us, sir.
A pleasure.
So one more,
Thank you
can
so
I ask
much.
one question?
Yes, yes, please go ahead.
So I'm Dr. Meenakshi Deshpande from Pune.
Yes, of course, I know
So it was a very wonderful talk. So can you just elaborate on what is the minimum size of fibroid which can be actually mapped properly?
Yes. So it's 2 millimeters.
2 millimeters.
Because
Yes. So
now what we
anything less than
started
2
doing-
millimeters won't be seen even if it is submucosal.
Yes, we might miss out on that because the frequency that we use currently is up to 15 megahertz. So in that situation, we're able to differentiate 2 millimeters. So you could have millimeter lesions sitting, which we will not pick up.
Okay.
But 2 millimeters is a fantastic amount to pick up, really.
Can I ask one question? Sir, that was an excellent talk. I'm Dr. Archana Kumari. I'm a professor in RIMS Ranchi. That you demonstrated the use of AI in such a beautiful way. This was something very new to us. Sir, I just wanted to know, how do you look for like degeneration? Even the fibroid of very small size, 2 centimeter undergo hyaline degeneration, so common.
Yes.
So how do you look for that?
So we could have a degenerated fibroid that shows no changes. In that case, we would purely by probe tenderness. A tender fibroid means that it's very likely that there's degeneration. Non-degenerated fibroids are not tender. And the second thing is vascular pools. So typically, you find vascular pools in old degeneration. In a fresh degeneration, you find focal hyperemia. But for focal hyperemia, you need a high-frequency transducer, and that is not yet available on many of the equipments. But typically, for those of us who are planning to buy equipment, we must buy high frequency, which means that we must be able to go up to about at least 9 and preferably 12 to 15 megahertz.
Okay. Thank you, sir.
Anybody else has any other question? We have served for a few minutes more. So if anybody has a question, they can ask. Otherwise, we will proceed to the next session. Thank you, sir. Now, what you told us about mapping, Dr. Mala is going to demonstrate. So she's going to take the surgical treatment. And I would like to introduce Dr. Alka Yadav, ma'am, who's a consultant gynecologist at Shanti Hospital, Narnaul. She, for 28 years with special interest in high-risk obstetrics, she is the president of Rewari Obstetric Gynec Society. She's a member of Oxy Public Awareness Committee, member District Medical Legal Committee, vice president IMA Narnaul, chairperson Women Doctor Wing Narnaul, best paper awardee at North Zone Yuva Foxy twice, and has attended various state and national conferences as faculty. We also have Dr. Hira Kodiatar, who's the president of Porbandar Society. So welcome, chairpersons. And Alka ma'am, over to you to please introduce Mala ma'am. Ma'am, you're muted. You're muted, ma'am.
Good evening, everybody. And thank you, Dr. Asha, for this opportunity to getting connected and learning so nice things. Uterine fibroids basically are definitely a nuances these days because they are late marriages and age-related fibroid incidences. So that becomes more popular for treatment of the fibroids in the women and infertility arising from that. So we have just had a very good talk on mapping of the fibroids. Now let's see what Dr. Mala Raj has to tell us new about the surgical management of the fibroids. Over to Dr. Mala Raj. Dr. Mala Raj is the founder of IAGE Tamil Nadu chapter. She is the managing council member of IAGE. She is treasurer OGSSI for year 2024. Joint Secretary Chennai Menopause Society 23-25, past Secretary IMS Chennai Chapter 2010 to 2012. She has training in advanced endoscopic surgery in Strasbourg and China Medical University. Foxy and ICOG recognized training centers are under her, trained in aesthetic gynecology under Dr. Red Allinson, California. She is accredited menopause practitioner Best Doctor Award from Tamil Nadu MGR University. Best Video Award in IAGE 2018 Lucknow. Operating Faculty in various conferences. Dr. Siuli Rudra Sinha Award AICOG 2006. Dr. Satya Paul Award for Excellence in Minimally Invasive Surgery IOG 2022. Authorized many chapters in various textbooks, currently Managing Director of Firm Hospitals. So over to Dr. Mala Raj to enlighten us on the newer methods of surgical management of fibroids.
Okay, good evening. Yeah, good evening, everybody. Thank you.
Dr. Khurana, sir, are you still there?
Yes, I'm very much here.
Sir, there is one question from P. Shrishala Govind. How to differentiate adenomyosis from fibromyoma and sarcoma? That is her question. And Dr. Rooplata has asked which machine is this?
Yeah. So basically, in terms of the echogenicity, the vast majority of fibroids would be relatively hypoechoic, which means relatively blacker than the rest of the myometrium. As fibroids get older and undergo various degrees of degeneration, they tend to become echogenic. And some of them that acquire fat inside them will become completely white. The problem lies in differentiating the heteroechoic fibroids from the focal adenomyoma. The adenomyoma is a lesion where you're able to identify a capsule for at least 25 to 50% of the outline of the lesion. In this situation, if you find round cystic areas and central vascularity, that is more likely to be an adenomyoma. And if you find peripheral vascularity, that is more likely to be a fibroid. But of course, one can always be mistaken for the other. Usually the vascularity in an adenomyoma is far more vigorous than in a fibroid. In terms of a sarcomatous change, sometimes you cannot tell anything at all, and a very benign looking lesion could be sarcomatous, and you cannot be accountable for that. But typically you find bizarre vascularity. So that was the blood vessel I was describing, where the parent vessel gives off one side vessel at a time, continues as a narrow vessel, and as it goes to the central lesion, becomes narrower and narrower. If this business becoming narrower and narrower does not happen, you can be reasonably sure that you're looking at a malignant tumor and not at a benign lesion. And then if there's still a doubt, then I depend on MRI, which is able to identify the blood signal within adenomyosis.
So the name of the machine?
Yes. So currently this AI that I showed you is on GE machines, and which has been introduced on one high-end machine, but we've also made sure that in India it's been introduced on one low-end machine. So if I may use the technical names, I don't know whether it's ethical or not, but it's important for us to know. The Expert 18, 20, and 22 are the high-end machines where this is available. And then we also have the Swift, which is a relatively medium-end or lower-end machine for 3D, and that also has it available. And the Swift has been specially pushed by us in India to make sure that all of us can give our patients the benefit of this artificial intelligence.
Thank you, sir. Thank you.
So, good evening, everybody. Thank you.
Sorry, Mala. Sorry for disturbing you. Please go ahead.
Thank you so much, madam. Thank you, Asha Jain, madam, for this wonderful opportunity, and all the best for you in your upcoming election. And it was such an excellent talk to listen to Dr. Ashok Khurana, sir. So it was beautiful when you can have such a wonderful mapping of the fibroids and you could operate on that particular patient. It is such a treat. So we had so many points to take home from your lecture, sir. Thank you so much for that. Of course, now that sir has beautifully described how exactly we can map the fibroids, let's deal like how we are going to tackle these fibroids laparoscopically. So currently, we all know the incidence of fibroids is really going up. Almost 30% of our women whom we see seem to be having these fibroids. It is not just one fibroid or two fibroids. We have patients coming with multiple strawberry fibroids like this as well, because these are all clonal tissues, clonal disease, which arises from from a single monoclonal fiber. So that is the reason why we are having these multiple fibroids these days, and it becomes a real challenge. So earlier days, we were doing an open surgery, but ever since Dr. Kurtzman demonstrated the first laparoscopic surgery, we have moved and evolved to laparoscopic surgery, not just with the technique, but with the help of the evolution of all the technology as well. We have decided why to open a door when we can do through a keyhole. So, of course, the figure has really helped us to see where exactly these fibroids are by proper mapping, especially when we have such an excellent radiologist like Dr. Khurana sir, who could help us with mapping of these fibroids. We can just precisely go take these fibroids out and come, especially for infertile patients, these are real boons. So in this topic presentation, I would like to discuss like how exactly we need to tackle these fibroids on various aspects, right from the decision making as to whether to remove these fibroids or not, and if so, which would be the better approach, and also what will be the incision and what exactly we do for hemostasis. Why exactly we need to do an intracapsular myomectomy, what kind of a suturing material and technique we need to follow, and also how we are going to retrieve these myoma at the end, and any post-operative additions we need to follow, and when exactly one needs to really convert, and also how to manage complications. So let us understand the fibroids. Of course, understanding of any pathology is mandatory for an efficient surgery, because once we understand the pathology and its clinical significance on that particular patient, we will be able to do justice to that particular patient. So we have quite a lot of theories thrown on the developmental of fibroids. And of course, now it has been understood that the steroid hormones and also the stem cells also plays a very, very vital role in the development of the fibroids, apart from the all other factors like the genetic and the epigenetic factors. So when we go, why exactly, when we have a patient with a fibroid, the most important thing that we need to understand is that why are we to remove these fibroids in that particular patient? So this is mainly based on the symptom that it produces, and also the age of the patient, and also what kind of a problem she is presenting to us, whether it is for infertility or for a bleeding issues. So ideally speaking, if we understand this, then we will be able to modify our surgical procedure. So in case of infertile women, they produce quite a lot of endometrial vascular disorders and inflammation, and this creates a very non-conducive environment for embryo implantation, and this is especially in case of even in intramural fibroids. So it is generally thought that intramural fibroids can be left alone, but this particular concept that these are the changes which occurs not just with the submucosal fibroids, even with the intramural fibroids which are not cavity distorting, can have its effect on the cavity. So that is the reason when all other factors of infertility are ruled out, we believe in removing in these intramural fibroids when they are over 4 centimeters, and when they are less than 2.8 centimeters closer to the cavity, even if they are not distorting the cavity. Of course, in these fibroids as well, the HOXA10 and the glycodylin are reduced, which were very essential for implantation. So once you remove the fibroids, all these revert, and you can see the fertility potential of these women going up. So the disruption or thickening of the junctional zone also increases the uterine peristalsis and causes implantation failure. So this is mainly because of the pseudocapsule in the fibroids, which causes so much of irritation on the junctional zone, and that is the reason why the fibroids result in infertility, even if it is not cavity distorting. So if you all see, the most important factor is the pathogenesis of the fibroids, not just for the structural defect, it's the biochemical changes which are produced in the uterine environment. So of course, the paracrine and the other factors like the progesterone receptors also plays a very major role in these fibroids, and in these women we can also see that the aromatase inhibitors are also affected, and as a result these women will have an elevated prolactin, and of course the elevated prolactin also is another major factor for infertility. So this is the most important thing. We all know that this is the peristalsis of the waves which occurs in the uterus generally generally speaking, during the proliferative phase, we can see that the peristalsis arises from the cervix and go right up to the fundus. And during the luteal phase, of course, we all know it is quiescent. That is the reason ovulation and implantation is occurring. And during the luteal phase, we know that it goes in the reverse direction. So if we have a fibroid like this, let us see about the intramural fibroids, because in submucosal fibroids, it is very clear that we need to remove it. So when we have an intramural fibroids like this, which is away from the cavity, the pseudocapsule will are in close proximity to that of the junctional zone, which would interfere with this kind of a peristalsis, and as a result, they cause so much of irritation, and there is an expulsion, and the implantation is hampered. So the various factors, of course, these are the implantation factors which are reduced, and also other factors which are also essential for the infertility, which are responsible for the infertility for that particular women. So, of course, the uterine peristalsis have also been measured by various authors, and they have found that there is a low uterine peristalsis is when they have less than 2 peristalsis in 3 minutes, and high uterine peristalsis is when they have more than 2 peristalsis in 3 minutes. So all these patients, they have studied and found that in women with fibroids, there is an increase in intrauterine peristalsis by using a cine MRI, and they have found that after removal of the fibroids, this intrauterine peristalsis has come down, and the fertility of these women have improved. So also the most important thing is the pseudocapsule. The pseudocapsule is a very like a double-edged weapon. It has pro-fertility and also anti-fertility effect. So anti-fertility is when it is with a fibroid. It, as I mentioned, it keeps irritating the junctional zone and prevents implantation. But pro-fertility is that while we are doing a myomectomy, we need to make sure that we preserve the pseudocapsule. That is the reason we keep saying that the surgery in fibroid should be an intracapsular myomectomy, because we want to retain the pseudocapsule, give it back to the uterus, so that this pseudocapsule is very essential for the healing of the wounds after the surgical procedure. This pseudocapsule contains bundle of smooth muscle cells and neurotransmitters, and it is also highly vascular and provides the blood supply to that of the myoma. So even from the surgical point of view, it is very, very essential that we remain intracapsular so that our bleeding is less, because we will stay away from the vessels. So the altered uterine peristalsis, which is due to the high neurotensin, neuropeptides, thyrosin, which are present in the pseudocapsule, as I said, hampers the fertility. And also the neurotransmitters produced by the pseudocapsule induce the uterine peristalsis. So it is mandatory to perform an intracapsular myomectomy. So the various steroid hormones and growth hormones have also been studied, and they have found to be also responsible for the growth of the fibroids. And they concluded that fibroids were larger when they were treated with both estrogen and the progesterone. Whereas those women who were treated with only estrogen or progesterone, they were much smaller in volume. And this shows that the estrogen and the progesterones were mandatory for the growth of the fibroids and for also the uterine peristalsis. And this is here, it clearly depicts how the receptors also plays a very, very major role in the development of the fibroids. So now, having understood the fibroids, let's look into the technicality of removing the fibroids. Of course, the most important instruments are the infiltration needle, which is essential to make sure that we perform a reduced blood loss surgery. And also, but good to have a harmonic scalpel or scissors, and also you should have a myoma screw, tenaculum, needle holder, suction cannula, bipolar energy source. Of course, you have to have a modulators. And now on our list, we also have an in-bag contained modulation. So we have the in-bag with us. So the port placement is the most important factor for the success of the surgery. A proper port placement will prevent the clashing of the instruments, and it'll, because here this particular surgery requires quite a lot of suturing. So unless and until the ports are placed properly, you will be clashing of the having clashing of the instruments, and it makes your job little cumbersome. So always place 4 centimeters above the topmost portion of the fibroids and the distance distance between the accessory port should also be 4 centimeters. And my method of entry in any laparoscopic surgery is direct endotracheal entry, which is an undervision, which is optional. You can enter it in whichever method of entry you're comfortable and which you have been schooled in. So this is exactly how this is an endotip looks like. If you see, it doesn't have a trocar. It just has a cannula with a outside screw, and you can see that I'm entering directly. So the camera is attached to that of the endotip, and you can see everything, visualize each and every layer in the monitor, and you can see the rectus sheath, you can see the muscle, and you can see the peritoneum. And the moment you read the peritoneum, you can see the underlying bowel, and that is the end point of my entry. And now I will create insufflate gas, and it will give the patient head-on position and introduce the accessory port. So the port placement plays a very vital role. And once here in a huge fibroids like this, it is always placed better. If you want, you can mark like this to determine where exactly we need to place the port, and put the primary port in the Lee-Hang point, which is the point between the umbilicus and the zipisternum. And once you are there inside, then you can place the accessory port, as I mentioned, 4 centimeters away from each other, so that we can tackle these huge fibroids laparoscopically successfully. So the dilemmas in this particular surgeries are, when we have a submucosal fibroids, it is a plethora of submucosal fibroids. We all know when it is a submucosal fibroid, it is a hysteroscopic myomectomy. But when we have a plethora of submucosal fibroids, or when we have a large submucosal fibroids, then obviously it is better to do a hybrid method, or taking the help of the laparoscopy to do a safe surgery in a single sitting, rather than doing multiple sitting with using hysteroscopy and also having complications. And also the intramural fibroids close to the junction zone and above 4 centimeters if other factors of to rule out other factors of infertility, and a large subserosal fibroids and fibroids of unusual locations. So now looking at the submucosal fibroids, of course, hysteroscopic myomectomy is the gold standard for the submucosal fibroids, but there are exceptions to this rule where laparoscopic myomectomy would be a better option, as in case of a large 4 centimeter submucosal myoma and a multiple submucosal myoma. Why? So when we have a situation like this, we are at crossroads. We're not knowing how to remove these fibroids. So there will be a plethora of submucosal fibroids like this. This particular patient, if you see, in fact, she was attempted a hysteroscopic myomectomy in Canada, and it was deferred because once they introduced the scope, this must have been the scenario. The entire uterus was studded with fibroids with absolutely no clean place of endometrium. So this is an infertile patient, and when you have to remove all of these fibroids, you will be damaging the entire endometrium. The basalis of the endometrium would be damaged. So the best approach I decided was to go and remove all of these 15 fibroids in the submucosal cavity laparoscopically. So the injection pitocin was done in laparoscopically, and then an incision was made on the anterior wall of the uterus, and then you can see that there are a few intramural fibroids as well. So this is another major advantage when we club it with a laparoscopic myomectomy as well, because you have the benefit of removing all the other kind of fibroids and also the other pathologies which may be associated with these fibroids. Here you can see the intramural fibroids are being removed laparoscopically, one after the other, and there were 3 of them which were removed laparoscopically. And once the 3 fibroids were removed, the peritoneum, the endometrial cavity was opened. So once the endometrial cavity is open, then it is like just doing a hysteroscope through abdomen. You introduce the telescope inside the endometrial cavity, you can identify all the fibroids and just pick one after the other using the myoma screw. So by doing so, you are only just holding on to the myoma and picking them up. Just by avulsing the fibroids, all the fibroids will come out. So you will not have to use any kind of a extensive energy source on these fibroids. Even if you have to use energy source, you can just gently use a harmonic scalpel. This is only condition where harmonic scalpel can be used inside the endometrial cavity. you can use a harmonic scalpel just to score the fibroid so that you cut only the pseudocapsule, and immediately you can see that the fibroids will walk its way out. So in this way, you can remove all of the fibroids one of the other. So the basic advantage is that you are not damaging the basalis endometrium because you are not, resecting the basalis as in the resectoscope in hysteroscopy. Then second advantage is that there is no worry of fluid overload. The surgery can be prolonged. So if you're going to attempt a hysteroscopic myomectomy for these patients, you have to ensure that you are able to finish the surgery as quickly as possible, which is going to be highly impossible in a scenario like this. And as a result, you may have to do in 2 or 3 sittings also. So which may be quite frustrating and annoying for the patient. So as a result, this would be a better modality in case of a plethora of submucosal fibroids. So as you finished picking up all these fibroids, you will see that at the end, you will have only a clean pink endometrial cavity rather than a charred endometrial cavity following a hysteroscopic myomectomy. So finally, once this is done, you can suture the myometrium and the entire surgery is accomplished successfully in a single sitting. And finally, the fibroids are morcellated and removed. So this is the reason why you need to do hysteroscopically and not, laparoscopically and not hysteroscopically in these kind of fibroids, because there is an increased risk of deeper invasion of these fibroids, which would be much comfortable doing laparoscopically, and of course the complications associated with the hysteroscopy also can be avoided when we do laparoscopically. So that is the reason laparoscopic myomectomy for a submucosal fibroid seems to be quite reassuring, and of course AAGL also has supported for submucosal laparoscopic myomectomy in certain scenario when the submucosal myoma is more than 4 centimeters. So now, yet another condition where a laparoscopic myomectomy can be done for the submucosal myoma. So that is in the case of a large submucosal myoma. We know that it is very difficult to pull an elephant through a hole. So as a result, we may have to abandon the procedure. So to make sure that we can accomplish the procedure, we can do it laparoscopically. Again, when we are at crossroads, we resort to laparoscopy. So here is a hysteroscopic view of a large 4 centimeters submucosal myoma, which is occupying the entire endometrial cavity. So after making a hysteroscopic evaluation, then making an incision onto the posterior aspect of the uterus, because the hysteroscopy now helped us to identify where exactly I need to make an incision to deliver this fibroid laparoscopically. So then the cavity is open and you can see that the fibroid will make its way out. Then slowly one after the other, as we are doing an mural myomectomy, you can see that the fibroid will also come out, and the entire fibroid in surgery can be accomplished completely in one sitting, and then finally you can suture the myometrium. So even when the endometrium is opened, it is one needs to understand that it is not mandatory to close the endometrium. We need to only just suture the myometrium above the endometrium so that this will help to maintain the integrity of the scar. But only thing is follow the correct principles where you do not leave any dead space in the myometrium, so that the entire dead space is completely occluded and you are able to suture the whole of the myometrium continuously and maintain a proper you are able to maintain a proper integrity of the scar. And finally a brace ball stitch can also be done, and finally put it in a bag and morcellate it inside the bag. So these are few articles which substantiates laparoscopic myomectomy for instead of hysteroscopic myomectomy for large submucosal myomas. And yet another article to substantiate laparoscopic for submucosal myoma, because the risk of rupture, there are limited evidence regarding the safety of labor following a large hysteroscopic myoma resection, because in hysteroscopic resection, when there is the myoma is more than type 2, that is, it is going in, there is more of the intramural component. The intramural component portion of the myometrium is not sutured hysteroscopically. As a result, it remains as a dead space. But in laparoscopic myomectomy, we are able to close the dead space, which favors the integrity of the scar, and the chances of rupture of the scar is relatively less with laparoscopic myomectomy. And also damage to the endometrium, as I mentioned, with hysteroscopy, there is more damage. When you have to do for not for simple submucosal myomas, but only in these two conditions, when you have a plethora of myomas. So these are the complications, and also now coming to the intramural myomas. Now, intramural myomas, as I mentioned in the pathogenesis, why we need to intramural myoma, not just for bleeding disorders, even for fertility, when all other factors or infertility are ruled out, and still the woman is not able to get pregnant, we can attribute the infertility to that of the intramural myoma and remove this, especially when she is undergoing an ART procedure, when she is symptomatic, when there are failed ARTS attempts, when it is closer to the junctional zone and it is more than 4 centimeters. So this non-cavity distorting intramural myomas and subserosal myomas, we also understood that they also cause significant pregnancy outcomes, more chance of preterm labor, and also abortions. And also they have found that the clinical pregnancy rate relatively improved after removing these myomas. And also these are the various literatures which substantiates why the pregnancy improved after the removal of the fibroids in these women. And also they have found that the pregnancy rate was low when the fibroids were less than 5 millimeter away from the endometrial cavity compared to those that were more than 5 centimeter away from the endometrial cavity. This explains the significance of the pseudocapsule. Now, looking at the post-myomectomy pregnancy rate, it has been found that the pregnancy rate is really good, and it is reported to be 57% compared to that of 49%. And also regarding there is no significant difference in the cumulative pregnancy rate or the obstetrics or the perinatal outcomes when laparoscopic and abdominal myomectomies are compared. So this is a case of laparoscopic myomectomy. This is the actually fertility principles which one needs to follow. Here you can see that I'm not using any energy source even to incise the uterus. So I have used only vasopressin to dilute, a dilution of 10 units in 100 ml, injected on the uterus, and then made an incision only using scissors. So only the scissors are being used to dissect the myoma out, and you can see that the entire myoma would come out with just the myoma screw and dissection with the scissor. This is the endometrium. You can see the small breach has occurred, but it does not require any kind of a suturing on the endometrium. So once the entire myoma is removed, then we can suture it nicely above the endometrium using, now with the advent of the barb suture, the suturing has become really easy. So we can just beautifully suture it above the endometrium in proper layers, and a single barb suture would suffice for the entire myomectomy. And finally, when you come to the serosa, you can take the baseball stitch. So this is the baseball stitch, the in-out stitch. So I generally prefer to use 2 needle holders instead of 1 needle holder, because it helps me to suture from my left hand while I'm coming from the opposite directions. So this helps. If you see, you will have a thin line scar rather than a rugged scar, and there is no exposure of the raw areas, and you will have a very clean pelvis. You will not have any kind of an adhesions in the post-operative period. So these women, if you deliver during cesarean section, you can see that absolutely the uterus is very, very free from adhesions. I have delivered this patient, and I was surprised. There was absolutely not even a bit of adhesion in that particular patient. And here you can see that finally we believe in putting the fibroids in a bag, modulating inside the bag and removing them inside the bag, and finally closing the port closure, that is the modulator port, because these ports can develop hernia later. So sometimes we can also have some huge fibroids like this. So in these fibroids, we don't have to use barb suture always. You can use a vital box stitch to bring both the flaps together. And then so once both the flaps are brought together with the box stitch, then finally, if you want, you can use the barb suture. So here you can also see that how the shoelace, sometimes you can also achieve hemostasis by doing a uterine artery ligation at origin. So here I'm doing a uterine artery ligation at origin, and this is by a temporary method called the shoelace technique. This is mainly to make sure that we are not compromising on the blood supply to the uterus and also to the not reducing the ovarian reserve. So the lateral wall of the pelvis is opened, and then here you can have the ureter, and also you can see the uterine artery. The uterine artery, you can see that the first branch of the anterior division of the internal iliac artery, the only privileged structure which can go horizontally in the lateral pelvic wall. All other structures would be going just parallel to each other on the lateral wall, and you can see the pulsation. So once you identify and confirm the uterine artery, and you'll also be able to appreciate the water under the bridge concept in this particular situation at the level of isthmus, and you can just throw a shoelace kind of a knot, and with this knot you can see that you can completely cut off the blood supply to the uterus for some time. And while this is happening, you can do the myomectomy because the blood supply is compromised a little bit, not that completely, because they have collaterals. And then finally, you are able to accomplish the myomectomy and finally unknot the shoelace knot which has been done. So just tug on the suture, and you can see that the shoelace knot get untwined, and you can see that the blood flow in the uterine artery starts resuming, and your uterus is again perfused very well, and you're also not going to compromise on the blood supply to the ovaries. So small little fibroids are more dangerous than large fibroids for losing the fibroids. So these large fibroids, they will not get lost. They will maybe be stuck under the bowel, but then small little fibroids is very difficult. So we string the fibroids. In the next video, I'll show you how we string it. So these are the uterine artery clipping, which we do. So that is in women who have already completed the family, where fertility is not a vital parameter. So in such a situation, we can just put clips instead of doing a temporary uterine artery ligation, where you can either put vascular clips or you can put titanium clips like this and occlude the blood supply to the uterus, and you can complete the procedure. So these are the small little fibroids. Here you can see that these are the multiple fibroids which you are taking. So here you can see that the ones as and when we are removing the fibroids, I'm stringing all of them into a string. So you can see that the myomas are all forming a mala. We call it as myoma mala. So you form a myoma mala like this and keep them aside in one corner, or you can park it on the rectus by anchoring it onto the rectus sheath. So these small little fibroids, you will not have to waste time at the end of the procedure going and picking them up. And finally, as and when I'm removing the fibroids, the string is now loosened, and you can string all of them. So finally, you get a big string like this. So another basic advantage of doing a string is that at the end of the procedure, you can just pick one of the string. There's one end of the string and drop the entire myoma inside the bag, rather than taking each and every myoma one after the other or searching for the myoma. This becomes a very simple procedure. So next, we also get sometimes not all fibroids we can give traction and counter traction and enucleate. There are some challenging myomas like this which are soft and cystic, which will be just like a cyst, and which also gives us heart because we will be thinking that we are dealing with that of a leiomyosarcoma in fibroid which are so cystic. So these are cystic fibroids. Again, we have to dissect and enucleate them properly, and then finally these 100% have to be put inside the bag and only be morcellated. More so because these cystic fibroids, if you do a morcellation without the bag, the entire tissue will be fragmented all over the abdomen, and you can see how much of tissue fragmentation is occurring inside the bag itself for this particular fibroid. So imagine if you had done a myomectomy for this patient, patient without a bag, all these bits and tissues will be lying all over the abdomen. So, and as a result, there is a chance for you to leave behind. So these are the bits and pieces and also the fluid which was inside the myoma. So all these were safely removed because it was an in-bag morcellation, and you can finally see that the entire myoma, so much of kidney trays of myoma are removed. So this is again another one. So you have like sir has beautifully mapped the fibroids. So with that help, we can identify these fibroids and decide where exactly we have to make an incision. The most important factor what I want to tell is that while making an incision, how are we going to decide the incision? Whether it is going to, so first, sometimes, the ultrasound, always we will not get some good findings like Khurana sir. You may get, the scan report which shows anterior myoma, and sometimes we will end up seeing a posterior myoma. In such a scenario, it is always better to have a look at the round ligament and see where exactly the bulge is. So based on where exactly it is, so we can relate it to round ligament and decide on where exactly.
Excuse me, Dr. Mala, can we cut short? काफी लंबा होता जा रहा है.
Okay.
We still have a panel discussion.
Okay, sure. Okay, so I'll forward few of the those also, and so these are the this is the subserosal fibroids which have been removed. So I will I think I'll skip. So this maybe you can see the parasitic, not parasitic fibroid. This is the fibroid which is arising from the lateral wall. So this lateral wall fibroid again if you see, it has got absolutely no connection to that of the uterus. So you can see this was actually reported as anterior wall fibroid, but this was having its origin from that of the lateral wall, and absolutely there was no. In fact, the second access report I have not made. I have finally just slowly tried to enucleate the fibroid from the lateral wall, taking care of the ureters and the iliac vessels, and the entire fibroids were removed after that. So this is myoma suturing in layers, and then sometimes you also have a fibroma arising in the ovary. So these are again another variety of myoma. So this sometimes you'll have associated pathologies. So any case of the myomectomy, it is always mandatory to make sure that you do a hysteroscopic hysteroscopic evaluation, because you can see some small polyps or something, and post-operatively, if she has bleeding, we can attribute it to the polyp. So ideally speaking, those can also be removed. So this is exactly the port side myoma which has occurred following an open morcellation which was done earlier, and she came with a fibroid at the port side. So this port side myoma was removed. So how many layers of suturing? Basically, you can just suture, make in two layers or maybe three, not more than that. The most important thing is you have to occlude the dead space. So this is I think adhesion prevention. Again, adhesion prevention is mandatory, especially in nulliparous patient, so that there is no distortion of the tubo-ovarian relationship and it does not, hamper her fertility. The subserosal fibroids, again, you have a huge one like this. The most important point.
Dr. Mala, I'm really sorry.
Yeah.
Means it's been too
late. Fine. Okay. Tissue retrieval methods. Of course, in-bag morcellation. This is a leiomyosarcoma in-bag morcellation. Okay. So, for want of time, I'm going to stop. I'll just skip all of this. This is intravenous leiomyomatosis, very interesting one, where fibroid developed in the uterine vessels. So, this is again for want of time. I'm going to show all of these, and we will skip all of this. This is again a fibroid, but which was thought to be a fibroid, but turned out to be an adenocarcinoma. And large cervical fibroids, and again colpotomy being done to remove it. Again, another method of tissue retrieval. So these are the various other fibroids, and of course, to conclude, of course, we all know fibroids, whichever is, we have to understand where exactly it is, the age of the patient, the the problem for which she has presented to us, and based on that, we have to decide how we are going to tackle it. So thank you so much. I'm sorry for if I have overshot my time, and I'm extremely thankful for giving me this wonderful opportunity. The entire team of Asha Jain, madam. Thank you so much.
Thank you, Dr. Mala. Thank you so much for such an elaborative and so nice presentation. Actually, I too got engrossed with the surgical videos you were presenting, and we were not aware of the time it was taking. It was really wonderful. The way you presented with that plethora of fibroids, the multiple fibroids, But ma'am, I wanted to ask you one thing, that how long does that endometrium take to heal properly when we are opening the endometrial? Usually we say that the endometrium should not be disturbed in fibroid surgeries, in infertility.
Yeah.
But we are doing it laparoscopically for the multiple fibroids. That is mandatory. We have to open the endometrium.
Yeah.
So does it take very long to heal and support the conceptus, or does it not take much time?
Yeah, basically, we have to wait at least minimum of 3 months, madam. Within 3 months, the endometrium regenerates beautifully. You can see that, she will start menstruating also. And also, if you do a second look hysteroscopy, you will not have much of an additions. In a situation where you are anticipating additions, like mainly in hysteroscopy, because here you are just making a small nick. So the chance of she developing additions is very less. Addition develops only when you have a damage to the basalis membrane of the endometrium. So that is not going to happen. That's a basic advantage. So epithelialization occurs in minimum 3 months. So minimum at least 3 months we have to give for these patients for the endometrium to regenerate.
That was really wonderful. Any more questions from the...
Do you recommend Mala madam? It is very good presentation and good videos we ever seen. And so many fibroids you are getting to operate in a one sitting. That is also very creditable. You are doing that.
Thank you.
So what I was to ask you that, are you giving any estrogen progesterone support for the endometrial growth after the myomectomy?
So after hysteroscopic or this kind of a myomectomy, I give estrogen and progesterone, madam. So estrogen, I give Proganova 2 milligrams TDS for 2 weeks, followed by progesterone for 1 week, and I'll allow the endometrium to shed. So they regenerate very quickly. So 3 months of estrogen hormonal supportive pills I give for that.
Thank you so much, Dr. Mala. So we conclude this session. Dr. Asha, all the good wishes for your elections, upcoming elections. We wish you all the best from our society. Over to you for the next session on panel discussion, please.
Yeah,
Thank you, ma'am. If any of you have time to spare, you can stay on, ma'am.
Sure.
Okay, and you can join in as well. So I'm really grateful to my expert and my panelists for joining in the very beginning and being here all the time. And I hope we will be able to take the panel fast forward and still finish it in about 40 minutes. So I would like to introduce my expert, Dr. Aarti Nimkar, ma'am, who's the president of Pune Obstetric Gynec Society. She's been practicing for more than 40 years, and her main interest is safe motherhood. But she has agreed to join in for fibroids. So thank you, ma'am. She's practicing at Suman Nursing Home, and she has a lot of very senior teachers as her guides. She has been secretary and treasurer of Pune Society, has the Dhanvantri Award, has Best Branch Award, Doctor's Day Award, and many more. So welcome, Aarti ma'am.
Thank you. Thank you very much for the introduction.
Our next chairperson is another very great person, Dr. Pushpa Janghare ma'am, who's professor and HOD, PDMMC Amravati, and she's a member of UG and PG Board of Studies and Surgery and Allied Subjects, member Faculty of Medicine MUHS, first visiting professor sent by Foxy to Cuttack Medical College, and she has many awards and many achievements. Ma'am is very senior and very humble, and ma'am, I'm really happy to have you here. Then we have Dr. Meenakshi Deshpande, ma'am, who's the director of Vatsalya Hospital at Pune. She is doing LLB third year. So great, ma'am. She's also the secretary of Pune Obstetric Gynec Society, member of NIMC Foxy, member of Cell Foxy, and she is also the member of District Authorization Committee of Organ Donation. past president of IMA Pune and has many awards. Welcome, Meenakshi Deshpande ma'am. We have Professor Archana Kumari ma'am, who is the East Zone Coordinator of Quiz Committee FOXY, Convenor Clinical Research Committee FOXY. In the past, Organizing Secretary FOXY East Zonal Conference with QA 2022. She is currently the Secretary of Ranchi Society and she is standing for Quiz Committee in this chairperson election.
Thank you,
So
Leslie.
all the best to you, Dr. Archana. Thank you for joining in.
Thank you, ma'am.
Has many awards and academic achievements. And if I may say so, too young to be a professor. So
thank you.
Next, we have
best wishes.
Dr. Anubhuti Mohan Singla ma'am. She is a consultant obstetrician and gynecologist at Sachdeva Hospital, Rewari. She is the secretary of Rewari Society, clinical associate of Lilavati Hospital, Mumbai, SR at MAMC Delhi, and has done her PG from Safdarjung Hospital, got the FOXY Best Paper Award in 2017, has many awards, achievements, and publications. So welcome, Anubhuti Singla ma'am. And all the questions I have put together have been from this paper which I shared. So I know I haven't shared any questions with you, but it's going to be very basic, and Dr. Mala Raj has actually taken all this in her lecture. So it's going to be basically just a revision. My chairpersons who are still there, I would be happy if you could join in as well. So if you have to describe it, what is a uterine fibroid? Anyone? Archana ma'am.
Yes, ma'am. Uterine fibroids are basically the benign tumor arising from a smooth muscle cell of the leiomyoma, and they are monoclonal in origin. Sometimes they can arise from the smooth muscle cell of the vessels, uterine vessels also. And of course, they are common in women of reproductive age group. But
so what is the incidence? Supposing a woman is 50 years of, if you have 100 women of 50 years of age and they have intact uterus, then how many would actually have a fibroid?
I think, I'm not sure of the exact data, but many of them would have, maybe more than 50%.
Aarti ma'am?
I think maybe there will be from 8% to 70%.
Yeah.
So it can
So
range.
the data says it is 70 to 80%.
Yeah.
More than 50%.
It's 70 to 80% women at the age of 50 would have fibroids.
Yeah.
So what I'm asking you is, everybody here is an expert. Does every fibroid require treatment?
No.
Definitely not.
No, definitely not. Only those fibroids which are interfering with the functioning, and maybe they are having an infertility problem. Because of that fibroid, only those fibroids need to be removed. Or those fibroids who are growing, in which there is a
those who
mapping.
are symptomatic. Those who are symptomatic.
So what are the three most common symptoms that we have with fibroids?
The most common is heavy menstrual bleeding, sometimes associated with dysmenorrhea, and then pressure symptoms. And if they are large enough, then they can become lump in abdomen. And they definitely affect the fertility. And some of the patients, when we are investigating them for primary or secondary infertility, they turn out to have fibroids, which may not be having other symptoms like pressure symptoms or menstrual disturbances, but that fibroid might be responsible for infertility. If they are especially in the submucous types, or they are blocking or distorting the shape of the uterus and sometimes the tubes also. So that might affect the fertility. So infertility might be presenting symptom some, but majority of them, they are asymptomatic. Many of them, they have menstrual abnormalities.
So basically we have three different kind of symptoms. One is because of the location and size. So just the weight and pressure on the bowel or the bladder, that way. Or you could have reproductive issues, or you could have bleeding issues. Okay. So we've already discussed at great length what are the different types and what is their location. So I will skip that question, and we've discussed symptoms. So why do they actually happen? What are the risk factors associated with development of uterine fibroids?
Actually, hyperestrogenism is associated because it will be increasing the endometrial thickness along with the uterine fibroids. And that will be also causing menorrhagia. It will increase the blood flow to the uterus. Plus, it will increase the blood flow to the endometrium, which we have, fibroid. So
Okay,
maybe
so
that is the risk
anybody wants
factor.
to differ? Anybody wants to differ? Dr.
times-
Anubhuti?
Yes, ma'am. At times there are genetic and epigenetic factors also which are associated with it. As ma'am has also described in her talk that HOMA gene is there. And apart from that, we do find MET12 gene, which is usually seems to be associated. These are the germline mutations which are still under study, and they may help us to develop newer treatment modalities for the same.
So that's okay. Dr. Aarti ma'am, I would like to ask you, estrogen, progesterone, or both? Which do you think is responsible?
Both. Both.
It's both?
Both.
And previously we kept saying that it's estrogen, but now we know that actually it's progesterone. It's not estrogen. So the estrogen also acts by priming the tissue to progesterone, and it is the progesterone that causes increase in size. So when we are prescribing progesterones for heavy bleeding and the cause is fibroid, we need to remember that, you know, what might happen in this case. So what, in your practice, I want to know, what imaging technique do you use? If somebody has multiple fibroids and has reproductive issues, what imaging do you use in your practice?
Mostly we use ultrasound, madam.
Ultrasound. 3D ultrasound is the better than the simple ultrasound or MRI.
Especially when we are planning myomectomy. In that case, it becomes very much important to diagnose the number of fibroids, sites of fibroid, size of fibroid, and other
So
things.
what do you trust more? You trust a 3D ultrasound or you trust an MRI? When you have to take, your patient is 28 years old, you have to take off a surgery. So what do you trust more in your practice, in your area?
Ma'am, in my area, actually, MRI is not affordable to every patient, especially in medical college. Of course, MRI is done in our medical college, but sometimes, as usual in government hospital, they are out of order, so we rely on 3D ultrasound as well.
Yeah.
Okay.
3D ultrasound is good enough, actually.
Yeah, that is good enough.
3D ultrasound with the good sonologist. It is important.
That is what Khurana sir said. That a good sonologist is mandatory. Because just a casually done ultrasound will not give you any information. And it has to be a transvaginal scan, because an abdominal scan alone doesn't give you images that are good enough. So if you don't treat a fibroid, the patient has come to you, there are almost no symptoms, it is an incidental finding that she also has fibroids. You let her go. But you're going to call her for follow-up in the future, right?
Yeah.
So what are you going to tell her? That, you know, these complications might occur. What are the complications of untreated fibroids?
When the patient presents for the first time or it is accidentally detected for by sonography done for some other reason, but later on she can become symptomatic.
Detected.
That is, later on it can cause heavy menstrual bleeding. It can grow in size, especially broad ligament fibroids. They can be causing problems with the urinary system. That is because of pressure symptoms. And they can then later on, they may become difficult to get operated. Sarcomatous change, fortunately, it is very rare. But I always tell the patients, if they are having minor symptoms and they are not sure about whether it should be removed or not, uterus should be removed or fibroid should be removed or not, especially for hysterectomy. If they are coming after 40 years of age and she is having size of fibroids enough, small enough so that we can carry out NDVH, Then one argument that I put forth, or one thing that I counsel is, if we do not remove it now, even though it is necessary to remove, it is not malignancy, we can definitely wait. But then they might increase in size, and then vaginal hysterectomy will not be possible. And we might have to resort to then abdominal hysterectomy. Laparoscopy surgery is not available everywhere for every patient. So this thing, that is the size of the uterus, it definitely decides the route of surgery. So that is one thing that we have to counsel to the patient.
Meenakshi ma'am, how do fibroids affect the fertility and pregnancy outcomes? You've done a first trimester scan, the patient is 8 weeks, and you find a fibroid on her posterior wall, okay, which is 5 centimeters in size.
Yeah.
Will it affect her pregnancy?
So if it is on the posterior wall and if it is abetting on the submucous area, so maybe if it is coming inside the cavity of the uterus, yes, then that will be encroaching on the cavity of the uterus. It will affect the implantation as well as the conception.
It's already 8 weeks.
Implanted.
It's already 8 weeks. It is implanted. So now what do you say?
I mean, it
you
is
want
a 8
to
weeks
treat her in
pregnancy.
pregnancy.
It is not 8 weeks
she is
pregnancy.
already 8 weeks pregnant.
Okay.
So the implantation is done.
Okay.
It's a healthy fetus at 8 weeks.
Okay.
So, and you have a posterior wall fibroid. Do you think it's going to impact her pregnancy?
That will depend upon the size now. So if the size is more than 4 millimeters, yes, it may.
I said it is 5 centimeter fibroid.
Okay. So it is, if it is more than, not 4 millimeter, if it is more than 4 centimeters, it may affect the growth of the baby. And the baby may have an IUD also later on. So I think if it is a 5 centimeter fibroid posterior wall, then one must consider.
I differ here. There is no need to treat this fibroid now because there are. I have
Aarti
seen the
ma'am is
pregnancy
speaking.
with the multiple.
Aarti ma'am, please adjust the camera. We can't see your face.
Oh.
Yeah. Thoda sa aur. Okay. Now please speak. Yeah. Better.
Because I have seen the patient with the multiple fibroids went to the term and we have done the cesarean section while finding the fibroid less space in the lower segment and did the cesarean and removed the fibroids afterwards. So there is...
No, that can be there. But what is the main idea that can the pregnancy go till term? If it is diagnosed at 8 weeks of pregnancy.
Definitely she can go to term.
She can go to term, madam. We have seen in our experience so many women conceiving with fibroid. Recently, I had one patient.
MTP definitely should not be advised.
No. That is not the concept of MTP. What I am saying is, should we advise patient to remove that fibroid laparoscopically?
Not
during pregnancy, never.
If it doesn't matter,
definitely not needed.
Pregnancy.
Not needed
to remove the fibroid during pregnancy.
So now,
be
being the
unnecessarily inviting
moderator, I
abortion.
have the final word, and I will say that if the placenta is not implanted in that area, it will not have any effect.
Correct.
Simple. And if the pregnancy goes on, because of the size, there will be discomfort, but most of the time it will not interfere with pregnancy. Therefore, we will carry the pregnancy forward, but we will counsel the patient that in 30% cases, fibroids grow in pregnancy. In 70%, they don't grow. So if it grows, it may cause problems for her. But to the pregnancy, not much problem is expected. Okay?
Yes.
So now what are the main goals of medical management? Why do you want to do a medical management? And when do you want to do a medical management?
Definitely when the patient is young and she is desirous of having children, that is, in fact, she might be having infertility problem, or she may be parous, but she wants to preserve her menstrual function.
Okay.
And madam, also when we want to avoid surgery in a symptomatic woman who is nearing menopause, or sometimes we want to treat her anemic status before surgery, and maybe she is not ready for immediate surgery. flexi-bones
So
type.
what is the size of fibroid that is going to respond to medicines? Because not, you have a 10 centimeter fibroid, it's not going to respond. So what is the maximum size of fibroid that will respond to medical treatment?
4 to 5 centimeters.
5 centimeters.
5 centimeters.
4 centimeters.
They should be less than 5 centimeters. If you are giving medical management for larger fibroids, that is simply to reduce the blood supply and maybe make the surgery of myomectomy or hysterectomy easier.
Yes.
But otherwise, they should be less than 5 centimeters.
Actually, less than 3 centimeters respond to medicine. More than 3 centimeters, you may have to give GnRH, then it will respond. It will not respond to anything else. So, we've already discussed this. What are the non-hormonal and hormonal treatments available? What all do we have? In our armamentarium, what are the things that we have?
In hormonal.
So we have, madam, oral contraceptive, LNG, IUS, we have SERMs, we have SPRMs, and then we have GnRH agonists, antagonists, lots of things are there in our armamentarium.
So what are you using in your practice?
I think we are most commonly using that leupride acetate injection, maybe for 3 doses or maybe for 6 months, just to prolong or to buy time for the surgery. Or sometimes we do use mifepristone, that is for a smaller fibroid, as you said, less than 3 centimeter. Or
we prefer mifepristone.
Yes.
10 to 25 milligrams.
Okay.
Yeah, sometimes
all the rest,
my
they
practice,
actually they reduce the blood loss. They are not going to reduce the size of fibroids.
Yes, most
that
of
is
the
majority of the
do not
medications.
reduce the uterine volume, madam. They are maybe temporarily, like GnRH agonist can temporarily reduce the size, but actually we have seen
rest, they do not.
after it is stopped.
No, but mifepristone does reduce the size.
Yeah.
So how many months can you give it? Now it was a 3 centimeter fibroid, multiple 3 centimeter or less fibroids. You have started her on mifepristone. Okay. How long can that medicine go on?
For 3 months. That was the main.
No, that is the initial phase. You give it for 3 months. Then
we monitor with the sonography if the size is reduced or not. If it is not reduced very much, we continue for another 3 months and then again monitor and see that the size is reduced or not.
Okay. If it is reducing, but not so much that you are happy with it, then will you allow her to have periods before you start again, or you don't want her to have periods?
We have to allow her to get the periods. Otherwise, she will develop the polyps. And with the endometriosis, endometrium, hyperplastic endometrium, and the polyp formation. So let her get the period and then continue again.
Yeah. So the guideline is she should be allowed to have 2 periods and then you start again. Okay. So now what is the malignant potential of fibroids? Everybody says sarcoma
it is very less.
different, fibroid is different. But what?
0.3 is the percentage. 0.3
yes,
sarcomatous change in the fibroid. Fortunately, it is very low.
Is it a sarcomatous change, or does every fibroid have abnormal cells? Stem cells and dividing cells, mitotic activity. Do all fibroids have it, or it's only the sarcomas that have it?
I think only the sarcomas. Not every fibroid is having.
Every fibroid has mitotic activity.
All the fibroid have.
That is the biggest thing that is why we are so unable to diagnose, because every fibroid has mitotic activity. And when you're doing a scan, it is the change in vascularity that actually triggers that something is wrong. So, though it is not very common, but there have been reports why the US banned morcellation was because they did a morcellation and it was a leiomyosarcoma.
Yes.
And there was a spillage and the patient was lost. one of my patients also went for fibroid, one-day myomectomy, and she went, and in 3 months she was dead because the whole tumor was leiomyoma. So it may be rare, but jisko hota hai 100% hota hai. So we need to be really aware and keep that in mind. Wherever in doubt, always it should be in a bag. And if you're doing open surgery, then even that you have to take due precautions. You cannot be just spilling everything everywhere. So now we come to the cases, and these are going to be really quick. We have like 3 minutes for every case. A 38-year-old woman presents with heavy menstrual bleeding and pelvic pain. She's 38. She has multiple uterine fibroids. The largest is 6 centimeters. She wishes to preserve her fertility. She's an IT person, hasn't had a child yet, married late. Now she has bleeding, and this is the state. What do you want to do? Means it's 6 centimeters. Do you want to go directly for surgery, or you want to give her some medicine for this?
If we decide to do surgery, it is better to go ahead with the surgery, because by giving this GnRH prior to surgery, it might change the planes of the fibroid, and later on it might be difficult to carry out myomectomy following these medications. It does reduces the blood supply or the vascularity, but it also affects the nature of the tumor. So the plane...
I totally agree, ma'am. But the patient doesn't want surgery. She wants to first have a child and then go for surgery. So would you like to give her...
Then we can definitely go ahead with GnRH and agonist.
So are you going to give her something, some add-back therapy?
Yes.
Yes. Initial 3 months, we may not give add-back therapy, but after 3 months, it is required. Maybe we can give tibolone, or we can give progesterone, or even...
Do you want to give a very low-dose HRT type tablet?
Can.
Yes, tibolone 2.5 milligram per day we can give.
No, tibolone is... What is the action? Tibolone is not really an advisable drug over here. You need to give 1 milligram of estradiol and a newer progesterone in minimal doses. So the new HRT pill that you have, the low dose HRT, that can be given. Supposing you've written the GnRH analogs for 3 months. The patient has not come back to you. She's feeling good and she's continued that. What side effects do you think she's going to have?
She may have hypoestrogenic side effects and such as hot flushes. She might gain weight, or there may be fluid retention can be there. There can be decreased libido also. All the side effects which we know of hypoestrogenism can be there.
Yeah.
She
do you think there'll be some effect on her bones?
Bone loss is more.
Bone loss.
Yes, obviously, bone loss can be there. The long-term therapy is taken without add-back therapy.
Now she has taken GnRH. She's taken it for 3 months. Now she wants fertility treatment. So you're going to give her GnRH and immediately start her on FSHLH, or there's going to be a transition with something else?
She can have the GnRH with progesterone.
Once she's on GnRH, ma'am, you cannot do ovulation induction. No? She's 38 years old.
Yeah.
So you have to wait for a period. And then you start your protocol, and then it would preferably be with FSHLH or HMG. The normal protocol giving letrozole or something would not really work here, because you have actually stopped everything.
Yes.
So now we come to the next case. This is a 45-year-old. She has symptomatic fibroids and now she's taken ulipristal and she's feeling good. But she read somewhere that it's not safe, it will cause liver damage. So how does SPRMs actually work? What do they do? Pushpa ma'am?
Yes, they are sort of anti-progesterone.
Progesterone. Yeah. So actually it is the
Selective progesterone
progestational
receptor modulators.
Yes. So they are blocked, so the progesterone doesn't act on the fibroid, and we already saw that it is the progesterone that
Progesterone
makes
dependent.
the fibroid grow. What are the side effects that you have with ulipristal? Actually, nothing happens except a little bit of vitamin D deficiency, which you need to give. But there is a class of patients which is unpredictable who get liver failure. So would you want to do a liver testing LFT?
Yeah. Yes, ma'am.
Of course,
It is
because
recommended.
cases are reported, so we would definitely like to.
But when? You want to do it before you start the treatment, or you want to do it 1 week later or 1 month
No, it is
later?
better to start at
usually
the outset
LFT
and then repeat after
yes.
3 months of use.
So what is
Ma'am,
recommended
you
is
would
now that
directly
we
do
should,
an LFT after 3 months.
No, better not.
no, ma'am,
At the
LFT
outset
should be
also we should
done.
do it. We should know what
Yes.
is the baseline.
It should be done before starting the treatment, and then it is
Should be done.
usually
Ideally, it
recommended
should be done
monthly.
before starting.
Yes.
Yes,
It is
monthly.
advised, it is to be started before, done before and then monthly.
Monthly, and
Okay.
then after we complete the treatment, still we have to go with a single report at least 2 to 4 weeks after the treatment has been completed. And if there are any signs and symptoms of liver injury, we have to tell that to the patient prior.
So are they effective? And are they safe? Ulipristal, is it safe and is it effective? It is effective, there's no doubt about
It is
it.
effective, of course.
It is effective. And is it safe? The answer is yes. For a majority of patients, it is safe. Because the liver damage is an idiosyncratic reaction, which we cannot predict. This is a 32-year-old lady. She has occasional heavy bleeding, not consistent, not every month. Now she is considering OCPs as a treatment option. Do you think that is the right option?
52 years, yeah.
Definitely.
Yeah.
Because if she is having mild symptoms like maybe heavy menstrual bleeding sometimes, what OCPs do is they reduce the endometrial thickness and reduce the blood loss during menstruation.
Yeah.
So, and she's 32 years old only. So definitely this is a good option for this type of patient.
So, but what are the benefits
ma'am,
and what is the limitation? What is the benefit and what is the limitation of using OCPs?
Benefit is
the
she is going to have
benefit
contraception also, apart from.
And the limitation?
It will not have any
It
effect
will
on
not
the size
reduce
of
the
the fibroid.
volume, madam. It will just
Exactly.
symptomatic
It will
treatment.
not have any effect on the size of the fibroid, and the fibroid may in fact actually continue to grow.
Yes.
Because she's getting both estrogen and progesterone.
So they act as growth stimulator for the uterine fibroid.
Yes. So this has to be really explained by us that you're considering OCPs is not a very effective way. So now she has said that, no, I'm willing to take that risk. I have only mild bleeding. So she's on OCPs. Now, how do you manage her breakthrough bleeding? Because if she has a submucous fibroid and the endometrium thins, she's going to have breakthrough bleeding. How are you going to manage that? Patients will come, na? आपने दवाई लिया, बीच में bleeding हो गया. What to do?
So
Will
we
you
can
just
increase
counsel?
the combination in which the estrogen can be slightly increased. That is a bit higher dose. Instead of say 20, she can be given
You
a
can give
combination of
30.
30.
Yes.
And if she is
Or
having
do you-
occasional bleeding, then it is better if she can use some other contraceptive. That is symptomatic treatment with NSAID. It will be a better option.
Okay.
So-
Would you like to put her on an LNG
LNG.
IUS?
Yeah, it is better. LNG.
If the cavity is not distorted, we can put her on a LNG IUS. But again, it is a progesterone.
Yes.
But it is not going
So-
to affect the size, neither going to increase nor decrease the size, but definitely it reduces the blood loss. And again, contraceptive effect or contraceptive benefit the patient will be. And it is known that LNG can definitely be used for patients with fibroids which are not distorting the shape of the cavity.
Okay. Now, this is a 29-year-old. She has dysmenorrhea and menorrhagia. She doesn't want any hormonal treatment. Hormones are bad. So, do you think NSAIDs will help her? You know how
NSAID
previously patients used to be taking
Fibroid.
spasmoproxevan. Nowadays, they take Meftal spas and they
Yes,
come
ma'am.
to you with that patta.
No, they will already come with, I'm already
No.
taking Mittal spas.
Yes.
So that does have a role because it is basically prostaglandin synthetase inhibitor and it will relieve dysmenorrhea, I think, and reduces bleeding also to some extent.
No.
Would you like to give her tranexamic acid?
It is a very good drug. In fact,
Yes.
along with that mefenamic acid, combination of tranexamic acid and mefenamic acid, it will take care of menorrhagia as well as dysmenorrhea to a certain extent.
So when
So
are you
definitely-
not going to use this? What are the contraindications of giving the patient tranexamic acid with mefenamic acid?
Mom, if a patient is having peptic ulcer disease or has a kidney disorder, or of course is allergic to the drugs, then we usually avoid these drugs.
Yeah. So before we prescribe this, we need to have a history of any acid peptic disease, right? Even if she's not had an endoscopy, but if she's reporting burning and belching, we need to have that history before we actually prescribe this. What are the side effects you expect?
No major side effect is there, but usually patient can say there may be mild diarrhea, nausea, vomiting. These are the only ones now, side effects with these drugs.
Okay. If she's taking tranexamic acid, 500 milligram, 3 to 4 times a day,
3 times.
will it cause any effect on her clotting?
Yes.
Do you want, deep vein thrombosis history you want to take or not?
Yes.
Yes.
Yes. Where to take?
This is a antifibrinolytic agent actually.
Yeah.
But actually
Yeah.
these are given only for few days.
Yeah, ma'am, but
So
actually
unless there
I've
is-
seen patients taking it for 1 month.
But why they should take it for 1 month? There is no need.
Because she went on bleeding, because she would take it only when she had bleeding, then she stopped, then she took it, then she stopped, like that. And she's been taking it off and on for a month.
Oh.
No patient should be
Instruction.
told that she
Proper
should take it
instruction.
beyond 3 or 4 days.
Yes.
When we are
That is
prescribing,
Instruct them
we
properly.
have to tell this.
Counseling
Yes.
during prescription is very important.
Yes. There was, ma'am was there now. Meenakshi ma'am, who's doing her LLB final year. So how are you going to
That is so
monitor effectiveness
inspiring.
over time?
Is she there?
How are you going to monitor the effectiveness over time? Tranexamic acid working or not working, mefenamic acid, will it have any effect on the fibroid?
No, it is not going to decrease or
No,
do anything to the size of fibroid. But definitely it is going to
Yes.
reduce only the blood loss.
Blood
That
loss.
is primarily the
Yes.
main action.
But she is taking it repeatedly. That means she is not getting any effect of the tranexamic.
Repeatedly means every month for 3 to 4 days only.
Yeah.
So
That is fine.
Not.
So now we come to the last case, which is a 42-year-old lady presenting with symptomatic fibroids, having heavy menstrual bleeding, and pelvic pressure. She has hypertension. And in spite of this, she doesn't want surgery. She started on mifepristone. How does mifepristone act?
It is anti-progesterone. It definitely helps in reduction in the size of the fibroid also. In fact, it produces amenorrhea in majority of the patients.
Yes.
That is, we are having that experience
So
that they are having.
she is 42-year-old.
Near the menopause, not near the menopause.
Not near the menopause. She's like midway.
Yeah.
So how effective? Is it effective? Yes, it is effective. What are the side effects of mifepristone?
She will get the amenorrhea first.
That is a desirable effect, actually.
That is desirable for her.
Yes.
And
she will get amenorrhea, that is fine, but the endometrium will become thick and bulky.
Yeah, it will become thick and bulky.
So when you do an ultrasound, you have a very huge one, and she is going to have heavy bleeding when she has a period after 3 months. You will not give it for more than 3 months at a stretch. You want her to have her period, and she's going to have heavy bleeding. And if she has hypertension, then how does mifepristone and antihypertensive work together? Does it work or does it not?
It will work.
It will work.
It will work.
Yes. So what are the protocols for management? When will you monitor her uterus and endometrium next?
After 3 months of treatment?
3 months, every 3 months.
Yeah, every 3 months.
Okay. Every means she should be allowed to have menstruation in between once or twice preferably. If at all we need to start again.
Treatment period.
Yes, ma'am?
Every 3 months of the treatment period.
Yes. So there are many alternatives. That we need a tailored approach depending on what is available, what the patient wants, and what we think she needs.
Yes.
And it should not be stuck in between just do this or just do that. And we need to keep updating ourselves like we already are. Now, from all my respected guests, I want a take-home message. And thank you so much for being here. Thank you for spending the evening with me. Please vote for me for Food, Drug and Medical Surgical Equipment Committee. Thank you. Thank you so much. Now we take the take-home points from everyone, and then we end the session.
When patient comes around perimenopausal age group.
Yes.
In that case, and we should rule out malignancy first, because simultaneously she might be having some atypical changes in the endometrium, or maybe having carcinoma endometrium. And once that is ruled out, it is better not to go ahead with surgery, because after a few years she is going to attain menopause. So that should be at the perimenopausal age group, when she is nearing menopause. Maybe
so sir has
47.
done the mapping and nothing is inside. So do you think Mirena will work here?
Will.
Yes, definitely.
Yes, it will.
Okay. What happens sometimes when you have very heavy fibroids, though they are not pressing on the uterus, the endometrium, but you've put in a Mirena, you need to explain that it might be expelled.
Yeah, because of the size of the uterus and the size of the cavity.
Yes.
Yeah. If the size is big.
And there is peristalsis, so it might be expelled. So, Dr. Anubhuti, one take-home message from you.
Not every fibroid needs treatment. So we as clinicians and gynecologists should know when not to operate and when not to give hormonal treatment to the patients.
That is the crux of the whole thing. Thank you so much.
Is what I was going
yes,
to
Dr.
tell.
Archana.
I was going to tell same thing which Anubhuti took my words. But of course, then the treatment requires counseling. It will depend upon the age, the fertility-related problems, and of course, the size of the fibroid.
And ma'am, we as beginners are learning this from our seniors. So I think maybe we have learned this right thing.
Yeah, that is the first thing we tell our students. Not all fibroids.
Yes, treatment of the myoma depends on the symptoms, age of the patient, fertility status, and the previous obstetric history, and the location and size of the fibroid. And we have to, and experience of the physician treating obstetrician, gynecologist. So it depends on everything. See the size, location, and do the mapping from Khurana sir and decide whether to remove or whether to treat medically.
Thank you, ma'am. Khurana sir, as you are already here, if you would say the last word before I say thanks and end the session.
You know, in the future, thank you so much for this opportunity. It's been excellent. In the future, what I really look forward to is that we have one transducer which you and me can hold as a clinician. And there's an automatic sweep, and automated, everything comes out as an automated report. So that would be the best way of mapping. And then I have AI to say, okay, these are the fibroids, these are your patient symptoms, this is the best option. So I think artificial intelligence is going to take us there. So it makes up for those of us who lack experience and for those of us who lack skills in ultrasound. The important thing in our country is that we have learning which is only from hearing each other rather than looking at evidence and checking it for ourselves. So those of us who are younger in the learning phase would benefit a lot from AI, both for mapping these and for the best option in that given case. I'll have a checklist. I will tick off my patient's symptoms. I will have a map. I put it into my computer and the computer says, these are the options to be discussed with the patient. That's what I really look forward to.
So that may come, but the human has always to be smarter than the AI because it is the human who teaches AI to AI.
It has to be human, yes.
So we need to be aware because as AI is evolving, my son is a data scientist and he can vouch for it. What it shows is most of the time not correct as AI stands today. So we need to be aware and keep our eyes open, enhance our skills and take things forward.
Yes, I do
Alka,
agree.
ma'am?
I do agree with you. And of
Alka,
course,
ma'am, one take-home point from you.
Ma'am, regarding this, actually, before giving any take-home point, I just want to ask one question when all the experts are there. Recently, I've had a patient, 16 weeks pregnancy. She came to me for the first time. She has two large fibroids, one 5 centimeter, one 6 centimeter. One at the left cornufundal area and the other one just anterior to it. Although I have dealt with larger fibroids than this, taking them to term and operating them successfully, but this patient is repeatedly coming with pain abdomen. Although there are no uterine contractions, the cervical length is okay, the lower segment of the uterus is okay. So what should I be doing for her pain? She's not getting relieved with anything, no analgesics. Just rest is there, but rest she cannot take. She's actually poor socioeconomic strata and she has to work basically. So
do a myomectomy, ma'am.
Should I advise her for that? If
do
she
a
accepts
myomectomy.
She is
She'll
basically
accept
mid-trimester. We can do that. Ma'am, the take-home message is that the patient has to be dealt with according to the pressure symptoms. AI and all that is okay, but when we are practicing in the peripheral areas, we have to be more dependent on our clinical judgment and what is best suited for the patient, that we have to deal with.
Ma'am, I agree with you in a way, but I would also say that it is up to us to tell the patient what else is available. We should not be making choices for the patient. Because
we do discuss it,
here we can do this. And this is available. You can get it done if you wish. That option I feel should be given because many a time when doctors take decision, they look at a patient, this is a poor patient, or this is a very, high socioeconomic status patient. What appears may not actually be the truth. So we just give the options and leave the choices to the patient. If the patient says, no, I am happy getting treated here, I want this, I want you to decide, we go ahead. But we should be the ones to give the options. So
no, ma'am,
correct
no
me if I'm
matter,
wrong.
we always give all the options to the patient. But because of the consumerism, you cannot always 100% decide for the patient. That is very important. You have to tell the patient all the pros and cons of the thing, treatment modalities which are available and which are best suited for her. But then ultimately the patient has to decide.
Yes.
Because the consumer law says we have to keep the ball in the patient's court, so that tomorrow the patient may not strangle your neck. That is very important.
Yes. Dr. Mani, you're still there, ma'am. Would you like to say something before we end the session?
She had to leave on an emergency call.
Okay. Thank you, sir.
Thank you,
Dr. Archana, Dr. Anubhuti, Pushpa ma'am, Aarti ma'am, and Alka ma'am, who are still here till the end. Thank you, all my respected guests.
To Alka ma'am.
Thank you, thank you, thank you.
And it was
Thank
so
you,
nice connecting to Alka ma'am,
Dr. Asha, and wish you all the best.
Madam, Pushpa madam live, and of course to Asha ma'am. Thank you so much, Asha ma'am.
Thank you.
Thank
so
you,
next
Asha.
week we meet again.
Yeah.
Next week we meet again, and the topic is labor monitoring.
Oh,
so
good.
Good topic.
You're going to enjoy it. Do log in, and we meet again tomorrow, next Wednesday. Thank you so much. Namaskar. Shubh Ratri.
All the best, Dr. Asha.
Namaste, Alka madam. Thank you. Madam, mere ko bhi all the best.
Thank you, Archana.
Thank you, Dr. Asha, for inviting me to
Definitely.
this webinar. Thank you very much.